National, Coun- National Council, in collaboration with AMBOSS, is proud to be present a live webinar on clinical examination. Whether you are a seasoned healthcare professional or a student just beginning your journey, clinical examination is a cornerstone of a patient care. It combines medical knowledge, practical skills, and the art of a patient interaction to provide accurate diagnosis and better patient outcomes. In this session, we'll be exploring the key components of a clinical exam, focusing on techniques, tips, and best practices. Our goal is to enhance your understanding and proficiency, whether you're conducting a general physical exam, a focus assessment, or a specialized examination. Now, prepare to be inspired and enlightened as we dive into an engaging session with one of the sharpest minds in this field. Let's give a warm welcome to Dr. Fidin Sanova, an experienced and dedicated medical doctor with a rich background in emergency medicine, public health, and a particular focus on sexual and reproductive health and rights. They have a history of working with national and international organizations to improve public health, human rights, and specifically fostering an inclusive approach to LGBTQ health. Their hands on experience, both in clinicals and policy making settings, has allowed them to hone skills in patient care, health literacy, and accessibility. Moving into the field of business and technology, they have been working in project management, strategic growth, and commercial development. Driven by a passion for sexual health, their future plans are specializing in sexology to ensure inclusive future plans, cultural sensitivity care for everyone, and development in this field, especially with the Turkish cultural context. Now, it's time to get to the real action. We are thrilled to pass the spotlight to our incredible speaker, Dr. Fidin Senova, who about to take us on a journey packed with a lot of knowledge and expertise. You go on, ma'am.
Thank you so much for that introduction and this warm welcome. I'm very excited to be here with you. As they mentioned, I'm Dr. Fidan Sanova. I'm an emergency physician, and my background has been in emergency medicine and public health. Today, we will go over how to properly conduct a clinical examination, tips and tricks that will help you throughout your careers, with a particular focus on the respiratory and cardiovascular examinations. Now, I want to start by asking a question to you all. Please answer in the chat if you have an answer for this. How do you start a clinical examination? When does a clinical examination start? There is no wrong answer. I want to understand what you think. I know there are people here from different stages of their clinical careers. When the patient walks into the room, entering a patient in OPD, as soon as the patient walks in. Yes. This used to be something that they drilled in us in medical school. This is correct. The correct answer is as soon as the patient enters the room. As soon as you see the patient, you will be able to start your clinical examination. Think of it like this. Is the patient standing upright? Do they look well? Do they look tired? How are their clothes? What are they wearing? Do they look sweaty? Do they look pale? There's a lot of things that you can tell by looking at a patient simply when they walk in, which will set the tone for your entire clinical examination. I see some other answers, such as after taking the history, as per the needs of the patient, which is not incorrect. That comes the physical part of the clinical examination. But when we say clinical examination, it is about your opinion as the clinician, as the physician, about what is happening with this patient. I will give some further examples about my clinical experience later on, but simply identifying from the clothes of a patient that they're a farmer and they live on farmland can give you ideas about what they have been exposed to, maybe certain bacteria that are zoonotic, so through transfer from their interaction with animals, or based on their dwellings, things like asbestos and other exposure chemicals that can affect the patient's care. I will open AMBOSS now and show you some examples of how we're doing the clinical examination, but I wanted to highlight this first before we begin, because every word that a patient says to you, every tone that they use, maybe even the language, maybe the accent even, can tell you something about how you will conduct your examination going forward. I will now open AMBOSS to go through some articles. I will first focus on the pulmonary examination, which is more than just listening to the lungs, of course, and then we will continue with the cardiovascular examination. Please ask questions at any point in time. I will give examples from my own cases, and later on we will also solve 3 cases from the AMBOSS database and give you the option to win some prizes. I'll get on the platform now. Okay, so this is what AMBOSS looks like when you sign in. It is all of these things that you see. This is based on kind of what you set your goal to. Right now, we're going to go to physical examinations to go through step by step what to do. On the left, you can click articles. Then we have clinical skills here. And this includes a very thorough section on history and physical examination. Now, I will go quickly through the medical history. There is not too much here that I want to show, but I want to highlight some points that I believe will be valuable for you. When you think of medical history, the patients will come to you with a complaint, right? So they will come in and they will say maybe, oh, my voice is going, I have a scratch on my throat. Or they will say, I have chest pain, I have headache, I have, I don't know, loss of appetite, I've lost some weight. It can be various different things. There are things that you will ask that is specific to what it is that they come to you with. You know, if they come to you with a headache, of course, there are specific questions that you will ask about that headache. But there are things that you need to know about every patient. Regardless of what the complaint is, regardless of where you are seeing them, this can be a GP clinic, this can be an emergency room, which was my main area of practice. You have to know some basics about the patient in order to be able to get them to tell you the correct information, because this is an art. Patients, they do not know what is important for their own healthcare. They may not tell you the things that will guide you to the right examination, right test, right diagnosis, because they don't know what is important. So you have to ask very targeted questions and build that trust and relationship with them so that they will tell you what you need to know. First step is always introducing yourself with confidence so that they know that they can trust you. They know that you know what you're talking about. You are the expert here, and they can trust you. They need to tell you everything that they can think of when you ask them these questions. So they come in, you introduce yourselves. Hello, ma'am. Hello, sir. I'm Dr. Fidan. Please take a seat. How can I help you today? What is your complaint today? Introduce yourself, let them know that you're an authority there, you're the person that will fix their problem, whatever it is. You may not be able to fix everything, of course, but you have to give this confidence to get them to tell you everything. Ask them their name if you don't know, if you don't see it on the screen. And then you get into the next steps. There are some basic things that you need to know, as you can see in this section also. There's a lot of things listed here. I'm not going to read one by one, but you need to get why they're here. So let's say it's a headache. They have a headache and it's been going for 3 months. Maybe they come in today. They come to the emergency with 6-month-old shoulder pain. You know, it happens. You have to ask why they decided to come today. If a complaint has been ongoing for a very long time, something must have happened now to get them to come in. Maybe the pain changed. Maybe someone in their family forced them to. Maybe someone in their family got sick. You will see this occasionally, that illness in the family will scare people into getting their own health checked as well. But it can also be that there is a change in the nature of the pain and the nature of the complaint, which is important for you to know when you're building your differential diagnosis. So you ask them, why are you here today? Why today specifically, if it's an ongoing thing? Then you need to know the basics about the patients, which is how old are they? Do they have any comorbid conditions, diabetes, hypertension? I recommend specifically asking, because when you ask patients, do you have any other illnesses? They might say no, because if they are not bothered in their day-to-day lives, they don't think of themselves as a patient, right? Do you think of yourself as a patient? You don't. But if you have even, I don't know, the glasses, right? I'm wearing glasses, I have myopia and astigmatism. This makes me a patient, technically, but I don't think of myself like this. Nobody does. So you have to be specific. Do you have any chronic conditions such as diabetes, hypertension, heart disease, kidney disease? If they say no, that's good, but ask them some specific things so that they understand what you're asking for. And then after that, you should ask them if they're taking any medications, because you ask them straight up sometimes, do you have diabetes? They say no. And then they go around and they tell you that actually, yes, they're taking metformin or they're taking insulin, but because they're not experiencing symptoms, it can happen. So clarification and knowing exactly what you're going for is always good to help guide you, because they may not be able to articulate themselves very well. So you ask about the specific conditions, you ask about their medication history, you ask about their past medical history, such as, have you been to the hospital before? When was the last time you were in the hospital? Have you had any surgery? Have you had any serious illness in the past? You have to clarify all of this. Again, with examples, it always helps to have examples. You should follow this by a social history. Do they smoke? Do they drink? Do they have any habits? It could be substance use, it couldn't be anything. But specifically ask these things. And if they say yes to anything, it's important to know the frequency. If they drink, how much do they drink? Do they drink every day? Do they drink once a month? If they smoke, how long have they been smoking? How much they smoke in a specific day? This is all very important when you're building your differential diagnosis. What I'm talking about here is, you can see on the screen the key elements of a focused history and getting the basics from a patient. Everything that I've said is listed. The next one is family history. I personally go social history before family history because I want to ask about them, have a broad understanding, then ask about their family. I follow that with, it's based on whatever their own history is. So if they say diabetes, do you have it in your family? If I see, visually, because clinical examinations started as they're walking in, if I see that they're obese, then I have to ask, do they have diabetes in the family? Maybe thyroid disease, maybe something else. There's a lot of things that can lead to what you're physically seeing in front of you. So it is important to check and understand if there is anything relevant. Now, this is something that you do regardless of whatever it is that the patient is visiting you with. You should do this. You should ask all these things to have a broad understanding of the patient. Over time, as you practice and you get experience, you will become faster with this. You will learn so much more, and you will have such a better understanding that you will be able to go much quicker, much faster, to be able to get through this very quickly. Review of systems. So this depends on the hospital. My hospital that I trained in Turkey, sorry, I'm a little ill. My hospital that I trained in Turkey, we had this in paper form. So I would go step by step review of systems. It included the skin and just overall skin conditions, then kidney, then hematological, then gastrointestinal. And you would ask the patients things like, for example, for gastrointestinal, you would ask, do they have regular bowel movements? Do they have diarrhea or constipation? This might seem irrelevant based on the patient's presentation, but you can look at the patient, listen to their history that they've told you so far, consider their symptoms, and ask targeted ones of these. You don't have to go checklist every single one by one, but think, renal system, am I thinking of anything that might be related to the renal system? The patient is obese, there's diabetes in their family. Then you should definitely ask, how many times do they go urinate during the day? Do they wake up at night to go urinate? Do they drink a lot of water? Do they feel thirsty, their mouth dry? So it becomes more relevant. But if the patient, looks healthy, they have no history of diabetes or anything like this, they have no symptoms that is related to the renal system, you don't have to ask this many specific questions. It's just kind of an evaluation. And again, this is the art of medicine. You will get more comfortable over time. In the beginning, when you're interns, when you're a house officer, I recommend just going through it. It will not hurt you. It will take a few minutes extra. You will gain experience, and over time, you will be able to focus it as much as you can. Now, this is what you do for everyone. On this article, you can go through and review at your own time as well. It gives you examples of specific questions that you can ask, what you should focus on in terms of understanding what the patient is talking about, how to ask about the social history. Social history also includes some sensitive things. So I come from a Muslim country. Asking about alcohol can be difficult when patients can be offended that you are asking this. Asking about sexual history can be difficult when patients see that as an attack on their character, on their morals. So here you will find examples of how to ask these things and how to specifically talk about them. And we also have the review of systems step by step. And you can see here that we have a checklist. So you can have this on your phone. Just open it up as you're going through things. Maybe not open it up in front of the patient on your phone. You can have it on the computer. It's okay to use resources always, but if the patient sees that you're using something, they might lose confidence in you. So open it on the computer so they don't see the screen, and then you can actually check, ask the right questions if you're seeing any issues, etc. And we have the full list here. Now, this is the basics of a history taking and the intro into the examination of a patient. Are there any questions here so far? If not, I will move on to cardiovascular and pulmonary examination specifically. You can ask anything, by the way. It can be about just emergency, because that's where I worked. I had some experience with general surgery and some experience with internal medicine, but I spent many, many years in emergency medicine, so that's kind of where I'm talking about, which is why I feel more comfortable talking about, cardiovascular and respiratory, because that's what I see. But I would be happy to answer anything. Sure. I'll go through pediatrics. Pediatrics is something that I absolutely love. In my country, like, we have it mixed. So the pediatric emergency is mixed with adult emergency. There is a two-layer system when it comes to pediatrics. You have to gain the trust of the parents, who are the ones, they brought their child to you. They are worried, they are scared. Often they feel guilty, because when the child is ill, the parents can feel like they did something wrong. They were a bad parent, a bad mom, bad father, and that's why the child is ill. So you have to convince them that you know what you're doing and you can help them. And you also need to convince the child that you are not a threat, that you can actually touch the kid and examine the kid without scaring them, so that they allow you to do the examination. A very basic example: if a child is crying, they will tense their muscles, their abdominal muscles. So that automatically means that it's harder for you to perform an abdominal exam. You cannot check for rebound or guarding or anything like this, because this is automatically harder when the kid is crying. So in my experience, what I used to do was I address the kid first. Regardless of the age of the child, it can be a 3-month kid, it can be 15-year-old, it doesn't matter. I first immediately look to the child. I go, oh, hello, welcome. And even if the child doesn't understand, again, this is even for 3-month-old. Parents like this. Parents want you to be personally involved. They want you to care about the patient. And I do care about kids. I love them. So it's just always a good idea to go to the kid first. Like, oh, hello, like, welcome to the emergency. Are you, what's wrong with you? And then turn to the parents and start having this conversation with them. The biggest barrier is that until a certain age, and even above a certain age, kids are not able to express to you the things that they're experiencing. So you are taking the history from a third party, from the parents. They are observing the child, but they cannot speak for the child. The kid may not be able to explain if the pain is like a stabbing pain or a diffuse pain or a pressure. It's hard for them to find these words. So you create a rapport with the patient, with the family, to get them to trust you, to get them to be more comfortable. I used to do this by making balloon rabbits with the gloves, the gloves that we wear, like the latex gloves or nitrile, whatever it is. That's what I used to do. Another thing, I have tattoos on my arm, and I have a cat. You cannot see it, but there's a cat on my arm. So I would ask the kids, do you like cats? Do you like animals? Or do you like flowers? I also have flower tattoos. So I would ask them, whatever it is. And usually kids love animals, you know? So I was like, oh, do you want to see a cat? And they would say yes. And they would stop crying. So I would show them the cat and they would like look at it and I tell the story of the cat. And then I give them a pen. Because I have all these tattoos, I give them a pen. And I'm like, okay, there's like empty space here. Draw a friend for the cat. So the child is busy drawing on my hand, on my arm, while I get to examine them without them crying. Automatically, everything is easier. Of course, not everybody has tattoos, but you can still do this. You can still draw a little cat on your arm or something. The idea is distraction so that you can actually examine the kid without the kid crying. So this is general approach to pediatric examination. The main thing is gaining the trust of the family and the child, and always explain to the child also what you're doing. Because if you just speak to the parents, the kids become they don't understand what is happening. The emergency room or the hospital is cold, it's scary, there's metal everywhere, they know that there's needles. Families can scare their kids sometimes, saying, if you don't do this, then you will get sick and you will go to the hospital, they will give you a very big injection. This is a Turkish thing. I don't know if they do this in India. Please let me know. I know that there's a lot of commonalities in terms of culture from my experience working with Amboss. But this is something that people do. They scare their kids into doing what they want. Parents say things like, oh, like I'll take you to doctor. Doctor will give you a needle, like an injection, just to scare them. So yeah, I'm not surprised to hear it's the same. So this means that the kids come in scared of you, So it's good to try to gain their trust in this way. Now, when you have a kid above the age of 1, it's much easier. Below the age of 1, you have extra considerations. The newborn period is a very, very special consideration. You have to be really mindful about the state of the child, and it is also hard to tell if the kid is well or not. So take extra care in examining them, actually expose their entire body, look everywhere, look at their work of breathing, listen to their lungs, listen to their heart. Don't forget that the base parameters are different for newborns and also babies of infants below the age of 1. They have higher respiratory rates, they have higher heart rate. This is just their base level of functioning. But you should still be able to tell, and these parameters, again, it's on Amboss. You can check on Amboss. You should be able to check if it's in the correct range. The important thing always, always is the child feeding. If a newborn or an infant is not feeding, that is a red flag. You immediately need to get support from pediatrics. Not eating, not drinking. I mean, if the kid is below 6 months, it should only be breast milk anyway or formula. Over 6 months includes food and water. But if they're not feeding well, that's a red flag and you should immediately consult pediatrics. If they are feeding well, then you can look at the secondary things. What is the color of their skin? Cyanotic heart disease is a congenital heart disease is a very big problem. It can be metabolic illnesses. It can be endocrinological illnesses. So a lot of things that you will not encounter in adulthood, you can encounter in that first year of life. So you have to be extra careful in your examination, make detailed notes about everything that you've seen and you've done. Pediatrics is one of the fields where you are sued the most. It's one of the most litigious fields. So everything that you document is something that is protecting you. And my professors always used to say, I'm sure yours too, if it's not written down, it has not been done. If you don't document it, you cannot prove it ever. It doesn't matter what you've done as long as it's not on paper. So be very mindful about documenting things very well for pediatrics. This is a general approach to pediatrics. I cannot go into too much detail because we have limited time. There is also a question about obstetrics and gynecology. I'll answer that and I'll move on to specifics of the cardiological and pulmonological examination. Now, so That's a very good question, sexual history, and I will tie that in with obstetric and gynecology. It is very hard to, it can be very hard to ask about sexual history in front of the family. I would recommend doing this as part of the review of systems. Act like it is a checklist that you have to ask for everyone, regardless of their age, if they're married, if you're suspecting anything or not. If you make it seem like it's routine, that you're asking this for everyone, then people will be less offended and less surprised about the question. If you can tell generally from the behavior of the patient if they are comfortable answering or not. Sometimes they will say no when they mean yes. And usually this is again the art of medicine. You will see them glance at their family for a second, or you will see them get a little flushed, or you can see their heart rate go up, or you can see a little signs, unfortunately, that show that they're not comfortable answering this question. I try to have alone time with a patient if they're above the age of 15, because it's important to value the privacy of the patient. And above 15, they may be doing things that they don't want their families to know, but the families are still bringing them in for pediatrics. So it can be quite hard in that way. But you can say it like, oh, I don't want to make the patient shy in front of you. You know, the patient doesn't want the mom or dad to see them. Very quickly, I'll just do a physical exam. So you can ask these questions while you're doing the physical exam and you're more alone with the patient. You're near them, right? You're next to the bed, you're, touching their body or whatever, and you can lean into them and whisper these things. If you can tell that they're not comfortable answering in front of their family. It is a good way of doing it. So say you're doing an abdominal examination, you're touching their stomach anyway. You can ask things like, how, your bowel habits. Do you have diarrhea? Do you have gas? Do you have any pain here? If it's a woman, when was the last time you had your period? By the way, is there any chance that you might be pregnant? Are you sexually active? But, bring the tone of your voice down and feed it in between other questions so that, the family might miss it. It's always best to do these kinds of things when you're alone with the patient because they might be shy. But yeah, so ask about, does it burn when you pee? How many times do you go pee during the day? By the way, do you always use protection? What kind of protection do you use? Like, it's difficult. There is no easy way to do it. Opposite gender, in my experience, sometimes can be good, sometimes can be bad. Sometimes people feel more shame talking to a person of the same gender because they think that they will be judged differently. They feel shy speaking to opposite gender, but they are more ashamed of the same gender sometimes. This is cultural. Again, I'm from a Muslim background, so it's a little different when it comes to sexual history. But it's also like not just religion, but also culture, where you have to deal with these things in a more sensitive way. This is, again, a part of the obstetrics and gynecological examination, but it is a part of every examination. Any patient that come to you, abdominal pain, burning while urination, anything can be, or a skin lesion. It can be a sexually transmitted infection. So you really need to make sure that you are asking these things because it is important. But it is not easy, of course. Okay. So this is a general approach to all of these things. I will now move to specifically the pulmonary examination. For example, right now I have a cough. It's hurting my throat. I also feel a little short of breath. You don't know my usual voice, but this is not my usual voice. It's a little hoarse. I don't sound like this normally. You have a patient like this. They walked in the door and they're coughing as they come in. And it's a dry cough. You hear it, like you don't hear phlegm, you don't hear anything. You have to mark that mentally. This patient is coming in, they have a dry cough. Dry cough can be many things. It can be due to vaping, smoking, shisha, but it can be due to an infection. It can be due to laryngitis. It can be due to anything. You keep that in mind. You get the patient's history. When did it start? Do you have shortness of breath? Do you have difficulty climbing up the stairs or running? How physically active are you? Because someone might look okay. They're not short of breath. They're walking very comfortably. They're sitting down speaking with you, but it might be decreased for their baseline. If they are more active usually, but now they cannot. In the past, they could climb up 4 flights of stairs. Today, they can only climb 2 flights. This is meaningful. So you have to ask these specific things when it comes to coughing, lung, coughing, shortness of breath, these kinds of chest pain, these kinds of complaints. How many pillows do you sleep with at night? Do you have difficulty climbing up the stairs? Do you feel tired? Do you do any kinds of sports? Do you take any medications? Do you have a history of allergies, of hay fever, of asthma? All these things. And accompanying symptoms. So runny nose, phlegm, the coughing, naturally. Loss of taste. Remember, COVID is not over. It's just that we are very highly vaccinated now, so it's not killing as much and it's not hospitalizing as much, but it is still a very common viral infection. Loss of taste. These kinds of things are very important to watch out for. You ask these specific questions, and then it comes to the physical examination. So what are the steps? There's 4 aspects of physical examination. Can anybody tell me what the first one is? We've been talking about this kind of, but we will do a better version of it now. Yes, perfect. Inspection, exactly. Inspection is the first step because it started already. So we start with inspection, we look at them coming in. When you're going into the specifics of the pulmonary examination, this now includes opening, taking the patient's top off, either just their back. If they're a woman, they might be more comfortable with that, or taking their whole top off. You can see a lot of things. You can see if their lungs are expanding in the same way. When you breathe in, both your lungs expand. So your back, your chest, it expands in the same way. When you have problems such as foreign body aspiration, atelectasis, pneumothorax, etc., that affect a single side of the lung, you will have uneven. So one side of the lung will expand more than the other. This is a very important sign for you. The color of the skin of the patient. Is it pale? Is it purple? Do you have any lesions on the skin? Do you see any problems? Sometimes you can actually see the heartbeat of the patient on their chest. We will also touch it in a second, but in inspection even, you can see the heartbeat of the patient sometimes, depending on their condition. So this is the first thing you watch out for. You see, are both lungs expanding? Are they expanding equally? The next step is auscultation. So you can listen to the lungs of the patient. With this one, I'll actually go to our article on this because it is quite a nice article. So here in the physical examination section, we can go to the pulmonary examination. Yes, inspection is what we were talking about. So are both of their lungs expanding? Is it equal? This also includes the respiratory rate. So how fast are they breathing? So versus, and how deep their breaths are. I don't think it's shown here. I cannot see it here, but yeah, it's down here. So ataxic breathing, irregular breathing in rhythm and depth. So it goes fast and then slow and different depths. This leads you towards one diagnosis versus another. And AMBOSS, in AMBOSS, you can actually watch videos of the breathing patterns of different patients. And this will help you understand, because until you see a patient in real life, this is the best way to learn, to watch someone else actually experiencing it. You can see an increased effort of breathing. This particular part is very important for pediatrics, actually, because even with a very, very simple lung infection, pediatric patients can come with usage of accessory muscles, so that you can see intercostal like pulls. You can see, what is this in English? The here, you can see a pull here, because all of the accessory muscles, the intercostal muscles, your diaphragm, everything is trying to pull as much as possible to allow for the breathing. And this is quite an effort for children because they're so small and they're already struggling. But you can also see this with adult patients. Cyanosis, as I mentioned, you can see it both in adults, but particularly in newborns and in pediatric patients. And associated, there we go. Dr. Mahek has linked this particular page also. I'm not going to read everything, but you need to look for anything else that might lead you towards the diagnosis of this patient. For example, one thing that is, I cannot see it there, but cirrhosis. Patients can have cirrhosis. Cirrhosis can lead to ascites, which is fluid in the abdominal cavity, which bloats up their abdomen. And that is a reason that their diaphragm cannot contract fully, and then they cannot breathe, right? So you have a patient that comes in with shortness of breath, weird breathing patterns, etc. But the actual cause could be something like cirrhosis, which is not a pulmonary pathology. It is important to just note everything that you can about the patient. Now, after inspection, after noting all the differences that you can see, the order of this can change. So it's palpation, percussion, auscultation listed here. In abdominal examination, this matters a lot more. You should do auscultation first because when you palpate, you change the bowel sounds. In the in the pulmonary one, it's not as important. With palpation, what you check is the symmetry of chest expansion. You can see it visually also, but by putting your hands on the patient, we actually have videos of this as well. You can evaluate the expansion of your hands as the patient is breathing. This again allows you to see if it's equal or not. Tactile fremitus is asking the patient to say certain phrases. They used to teach us different things. I think this is a language-based thing. So asking a patient to say toy boat does not really make sense, whichever language you're using to speak with your patient. We used to say bir, which has the r and k sound in it, and it means 40, 41 in Turkish. We used to say that it is something to make the vibrations, basically. If a patient has any kind of consolidation in their lung, so one lung has more fluid than the other one, basically, in it, this can indicate certain pathologies, and it will vibrate differently because think of it like a full water bottle versus an empty one. They do not have the same weight and movement, and they don't transfer the vibrations in the same way. I wish I had some water before I sat down. With percussion, again, very similar to the palpation, where you're trying to tell if there is any obstruction, if there is any fluid, anything else, you percuss the intercostal spaces. So you put your finger in between the ribs on the back, so it should be between the scapula. You're not supposed to do it over the scapula, so between the scapula, going down and out. We do have images of this. Let me find, there we go. So what you're supposed to get is the area between the scapula and between the costa, between the ribs. You are supposed to find the actual lung tissue, and you start from the top, you go down and out, and you should do this one by one. So don't do the right side first and the left side. You should do one right, one left to be able to compare, because the top of the lung will sound different to the bottom of the lung. So it is not it's not a good comparison. But if you go top right, top left, middle right, middle left, you can actually compare it to an equal tissue. And you can tell if one side has an obstruction, an effusion, anything like this that will guide you. These are also the same spots that you can listen from. You ask the patient to take a deep breath in and then give it out. And you're supposed to hear it both in the same area, which will give you the most complete picture of how the patient actually is. You can see we have some wonderful images here. This is an example of pleural effusion. So when there is effusion, there's basically liquid in that space. You will hear this section differently, so your auscultation will be different, and also your percussion will be different. I'm very sorry about the coughing. The percussion will be different because Again, like empty water bottle, full water bottle. When you tap it, you will hear a fuller sound. And when you listen to it, it'll be more muffled. You will not be able to hear a full inhale from this region. We have a full video, which you can watch in your own time, that goes step by step through every aspect of the pulmonary examination. Oops, let me turn the volume off. But they show you exactly where to put your hand, how to do the examination, what you're supposed to be hearing. I will not go through everything. I will move on to the next steps. But you can actually review all of this. And the images that I was just showing, they're also on the patient here, step by step, so that you can visualize it. We learn anatomy in the labs, in drawings, on cadavers in some hospitals. It is not the same as actually having a patient in front of you. I should also note that this is a healthy-looking, average adult male. You will have patients that have hunchbacks. You will have patients that have skin conditions on their back. You will have patients that are obese, that are, or the opposite, malnourished. This will change. This is showing you the optimal way of doing this, but there will be difficulties in your actual clinical practice. Please watch these, and it will really help, I think, in your understanding. We have a table here. This table sums up basically all the different things that you can find and you can see in your examination and what it could potentially mean. Because there is not really something that says, oh, if you have this sign, it is 100%, no competition, no contest, this condition. It's not how medicine works. There is always multiple opportunities, multiple possibilities. So this table guides you in how to get the correct differential diagnosis. Okay, so auscultation, breathing sounds. Do you hear it decreased or absent? You look here, okay, decreased. Pleural effusion can be decreased. Pneumothorax can be decreased or absent. You go down. Atelectasis may be decreased. You go down. Tumor, possibly decreased. Depends on the tumor. So these kinds of tables allow you to have an understanding of how to create a differential diagnosis actually, and how to go have a more comprehensive checkup going forward. It is not shown on this article, but another thing that you can do is a chest ultrasound. This is a point of care ultrasound. You can, this is something that we used to do more commonly in children, where it's hard to get them to comply with x-rays. They will not hold their breath, for example, or they will not sit still. So with the ultrasound, you can actually evaluate the lung parenchyma, so the lung tissue, to see if there is effusion, if there is any kind of collection, if there is an object, because kids love to put things in their mouths, unfortunately. That is also another thing that you can do, which is not listed here. And it is in the emergency room, it is a part of your examination because it's bedside intervention. Before you send the patient off somewhere to get an x-ray, to get blood work, etc., you can do it right there and it will give you an idea about how to proceed. Yes, so inspection, palpation, percussion, and auscultation. These four is the same. Like we have these four for every single system. The order can change and what you're looking for can change, but this is the basic approach to all physical examination, and these are the specifics when it comes to pulmonary examination. Do we have any questions for this? If not, I will go into the specifics of cardiac and then solve some questions. All good. Let's go to cardiac. Now, a lot of things are similar with the cardiovascular system because the cardiovascular and pulmonary systems are very, very closely linked. This means that a lot of the things that you expect to find as a problem in the pulmonary system, you can also expect to find here. Now, when it comes to the cardiovascular system, it's important to remember that it's not just the heart, it includes the vascular system. So blood pressure, jugular venous pressure, and the pulses become very important. What is the blood pressure of this patient? Is it equal in both arms, in the arms versus the legs? What is it high? Is it low? And what is the pulse pressure, which is the difference between systolic and diastolic, and it can indicate different problems. It's important to do this correctly. So the patient, they waited in line to see you. It's hot outside. They walked to the hospital. It is not possible to get a correct blood pressure reading like this. So you need to sit the patient down. While you're taking the history, the patient will have calmed down a little. The heart rate will have slowed down a little. Then, then you will be able to get a more accurate blood pressure reading. One thing that is important to note here is that some patients are afraid of doctors, and they might have slight hypertension, which is called white coat hypertension. Their blood pressure readings at home will be fine, but with the clinic, they will be a little high. It is not possible to avoid this, unfortunately, because of their discomfort. So if they don't have any other problems, and if the blood pressure increase is mild, it is not that big of a deal. But it is something to note that the patient might have this anxiety. Again, we have videos showing you how to do this. Here it talks about some errors, such as the white coat hypertension and the patient being exhausted, walked, etc., exercised. Then we have the jugular venous pressure. There is a video of how to accurately do this, but it is basically about having the patient in the right position to identify sorry. It's also very late. To identify the level of elevation, which again, you can see from this video, and also to understand what it means. There's, again, we have all these tables, all the images that explain to you what this is. And the pulses. Is the pulse regular? Is the pulse full or weak? When you're taking a pulse from a patient, like the radial pulse from their arms, you can tell if the blood pressure is high or low because it's going to be stronger or weaker. Or you can tell if it's rhythmic or not. So if it's if there is any arrhythmias or things like this. So this gives you an extra understanding immediately as you're seeing the patient without having an ECG, for example, without even getting their blood pressure yet. You can just touch a patient's arm and get that information. I was on a long flight recently from Canada to Istanbul. I was sleeping on my seat, and someone collapsed next to me. They hit the floor, and I woke up to the sound of them falling. And it's middle of the night, it's completely dark, and I didn't even understand what was happening at first. As soon as I did, I got up, I looked at the patient, and what do? Someone collapses. First thing you do is you check if they're breathing, you check if their heart is beating. So you check for a pulse, you check for their breathing. He had a pulse, but it was very, very weak, and he was unresponsive. So I was trying to get him to wake up, basically, to respond to me. But I could feel, right? I could feel a pulse, but I could also feel that it was very weak, which can indicate a lot of different things. It ended up being orthostatic hypotension due to the patient's medication interacting with alcohol. But initially, even before I checked his blood pressure with the cuff, I knew that it was going to be low. And then when we checked, it was 80/50. So it was quite low. Then we have, again, the same steps of inspection, palpation, percussion, and auscultation. Inspection includes the same things. You just check for extra things such as what I mentioned before, the visible apex beat, if you can see the heart beating from the outside. You can see any scars for surgery, pacemakers, any deformities. This is the same ones that you're looking for in the pulmonary one as well. Then the palpation. Where can you feel? Because with your hands, you should be able to feel the palpation of the heart. Where exactly are you feeling this? It matters kind of the position, and this can indicate things like cardiomegaly, dextrocardia, things like this. So where exactly is it beating? You can also see other things. Sometimes you can feel the murmurs of the heart, even before the auscultation, where you're going to hear and look for murmurs. You can feel them with your hands on the patient's chest. So it's one of the things that you're watching out for. There is no particular cardiac chest percussion, but the same things that you did for the pulmonary, you should also do here, because it is a complete examination when you're doing them both. With auscultation, there should be an image here. There we go. With auscultation, it is important to know where you are listening to and for what. So you listen to the aorta in the second right intercostal space, and you listen to the pulmonary pulmonary valve on the left second intercostal space. As you can see, we have the different points here, like tricuspid, mitral. This is called the ERB point, which is for it's a very good single spot location to get a better understanding of the heartbeat. And this just overall gives you an understanding of where to listen to. And we actually have recordings here, so you can listen to the heart sounds. We have examples of what they sound like if there is nothing wrong, and we have examples of the problematic ones. You should be able to hear pum 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 pum, so 2 beats, S1 and S2, and they're different. Their intensity can change for various reasons. You can hear a murmur, which is essentially water flow, blood flow. You hear, it can be different. So it can be between the beats, it can continue throughout, it can be after one or before the other. So it can be in different parts of this process. We have here, let me see, I'm sure we have heart murmurs, there we go. So this one tells you when you can hear it and what to look for when you are trying to identify what is wrong. Again, we have examples, so you can listen to them at your own time. There is also extra heartbeats that you can hear, S3 and S4, based on some particular pathologies that you can experience. It is not important to know what exactly it is. It's just the main goal here is, are you hearing 2 heartbeats? So bum bum, like S1 and S2. Do you hear anything extra? Do you hear a murmur? This is just to give you the flag. I should look into this further. I should explore this further. As a junior physician, you will not immediately have the capacity to do these further exams yourself. You may not know how to do, for example, how to do an echo, and the patient might require an echo. So it is just, the goal is identifying if something is wrong. So you should know what the normal sounds like to be able to continue and do the abnormal. Okay, what else is here? That is pretty much it in terms of the cardiac examination. A lot of the things that you do for the pulmonary, you should do here. You should listen to the lungs. Patient comes in with chest pain. It can be anything from they went to the gym and they normally don't work out, so they have a lot of muscle spasms and they're scared because it's sharp stabbing pain here. It can be a pulmonary pathology. It can be an infection. It can be pneumothorax. It can be a tumor. It can be anything. It can also be an MI. It can be a cardiac pathology, endocarditis, myocarditis, etc. It can be gastritis. Gastritis and reflux can present with chest pain. So the goal is to make sure that you don't miss any part of this. Again, you may not be able to diagnose everything immediately. That's okay. What you should know is what the healthy looks like. If you know what the healthy looks like and what the healthy sounds like, then you will be able to understand this is wrong. This should not be here. And this is a very important aspect, because after that point, you can get support from your senior, from a resource like AMBOSS, from a different department. But if you cannot identify when something is wrong, that's when the problem begins. You will not, if I asked you, you will not be able to list every single potential differential diagnosis for a case presentation, which we will try now, actually. We will look at a question. Do all of them? Yeah. But that's okay. You do not need to know every single differential. What you need to know is what the normal is and how you can move out of that normal. I would like to now do some questions as the end of our session. And there is one more question and I will answer that afterwards. 1 second, sorry. This is the question that we will do. Yes. So this question is about an examination. 14-year-old boy is brought to the physician for generalized fatigue and mild shortness of breath on exertion for 3 months. History of recurrent patellar dislocations. He's at the 99th percentile for health, for height, at the 30th percentile for weight. This tells you that this boy is very tall, but also very skinny. This indicates certain conditions. His temperature is 37 degrees, pulse is 99 per minute, BP is 140/50. Examination shows scoliosis, a protruding breastbone, thin extremities, and flat feet. Ocular examination shows bilateral upwards displacement of the lenses. A grade 3 out of 6 early diastolic murmur is heard along the left sternal border. Do you remember what the left sternal border was? We just looked at it. I very briefly passed it, but you might remember. Further evaluation of this patient is most likely to show which of the following. Now, you can see here that the options are other symptoms that we will see. But the important thing to note, actually, is that all of these things indicate a particular condition, a particular genetic condition. So because we're supposed to be able to identify that condition and then go from that back to the other symptoms that it can have. Okay, aortic regurgitation. A, there's C. Okay, the first answer was C. Let me try that one. That is incorrect. This patient has Marfan syndrome. Marfan syndrome, you might know from Michael Phelps. Michael Phelps, the famous Olympic swimmer, has Marfan syndrome. They tend to have extremities that are longer than usual in terms of proportion. They also have several cardiac pathologies, unfortunately. So the first one was C, then the second person said A. Let's try that. No, that's also not it. I see water hammer pulse, and that's the correct answer. N, I cannot see your full name. Please send us your email, and you will be getting complimentary Amboss access. So a water hammer pulse is, and now, when we answer the incorrect ones, you get the explanations for the incorrect answers as well. When you get to the correct one, it links to the particular, let me get this up. It links to the particular problem that this question was trying to solve. So it explains to you what it is, and you can click to get a little pop-up with further explanation, and you can also click this here to get the article open on the right, so that you can actually see what it was actually referring to in the article. So that is how we can see. Let's do one more question. This is actually not a very pleasant one. Let me move on to something nicer. This one's better. 62-year-old man comes to the physician for decreased exercise tolerance. This is something we talked about in terms of the pulmonary examination, also very relevant in cardiac examination. Over the past 4 months, he has noticed progressively worsening shortness of breath while walking his dog. He also becomes short of breath when lying in bed at night. Shortness of breath while lying in bed at night is also supposed to make you think about heart failure. His temperature is 36.4, pulse is 82 per minute, respirations are 19 per minute, and blood pressure is 155/53. Cardiac examination shows a high-pitched decrescendo murmur that occurs immediately after S2. By decrescendo murmur, it means that it starts off stronger and goes weaker. So, you know, kind of, that's not a very good replica, but you get the idea. And is heard best along the left sternal border. Again, same as the other one. The left sternal border is where we listen to the pulmonary focus point. There is an S3 gala. Carotid pulses are strong. Which of the following is the most likely diagnosis? Do we have any guesses? D. The first guess is D, which is correct. Revati, fastest and correct answer. It is an aortic valve regurgitation. It is very good to understand when these sounds happen to be able to connect these more easily to the pathologies. What is S1? What is S2? Which valve is closing and making the sound when we are hearing the specific things? This allows you to understand, okay, so if the sound is happening after, for example, the aortic valve has closed, that means that maybe there's something wrong with that valve and there is regurgitation. Yes. Please, Dr. Mahek's in the comments. So please just send us your emails and we will be able to get you the gifts. And I will do one more question about the pulmonary, and that is the time. I will let you go afterwards. Okay, let's do a question from here. I'll do all of them. Cool. Okay, let's do this one, and this is the final one. A 65-year-old man comes to the physician because of shortness of breath, chest pain, and a cough for 2 days. The pain is exacerbated by deep inspiration. He has a history of congestive heart failure, hypertension, type 2 diabetes, and hyperlipidemia. This is actually a very standard patient. You will see a lot of 65-year-old men who come in who have all of these chronic conditions, and you can be sure that they're all poorly managed. They smoke, they drink, they don't take their medications correctly. Look at this patient. Current medications include metoprolol, lisinopril, spironolactone, metformin, and simvastatin, so 5. So polypharmacy is an issue here. He has smoked half pack of cigarettes daily for the past 20. This is a very, very classical Turkish uncle. I've seen this exact patient hundreds of times. So his temperature is 38.5, so a little elevated. Pulse is 95 per minute, respirations are 18 per minute, and blood pressure is 120/84. Oximetry shows saturation of 93. Examination shows dullness to percussion and increased tactile phremesis in the right lower lung field. We talked about this. Dullness and the tactile phremesis, which is the vibration, like full water bottle, empty water bottle. This is what we're thinking of. Auscultation over this area shows bronchial breath sounds and whispered petriloquy. The remainder of the examination shows no abnormalities. Which of the following is the most likely cause? Okay, let me see. The first one was A, parenchymal consolidation. Correct. Dr. Sushant was the first person to answer correctly. So please give your email, Dr. Sushant, to Dr. Mahek in the comments so we can get you your gift. So parenchymal consolidation. This is exactly what we talked about, right? So when you listen over there, you will hear muffled sounds. When you percuss, you will hear dullness. It means that it's full, basically. It's not empty. There's less air in it and more fluids and more inflammation. So this is likely pneumonia. This patient has been smoking. They have tons of illnesses, congenital, comorbid illnesses, and they have a fever. They have not so much tachycardia, but like a little tachycardic, like 95 is like nothing worrisome, but and slightly low saturation. So 93 is nothing to panic over, but it still indicates a bit of damage. So yeah, this patient has most likely has pneumonia. And that's it. Thank you so much for being here. If there are any final questions, I can answer them. I don't want to take too much of your time. We're already 3 minutes late. But I hope this was useful for you. Please go to Amboss, go to the article section, as I showed, clinical skills. You can watch every single thing that we talked about. You can see how to do each of these examinations. You can see the correct sounds, the normal sounds, hear them, watch the videos, read the articles, read the tables, and become much more prepared. And as I said, don't focus on learning all the different signs. Focus on having a very, very good understanding of what is normal. What does a normal examination look like? Then you can figure out exactly when something is wrong. And you can catch the smallest things, the littlest things. Thank you. Thank you so much.
Thank you, ma'am. We would like to express a heartfelt thanks to our speaker, Dr. Fidin Senova, ma'am, on behalf of the organizing committee. for sharing her experience and knowledge to all of us. Last but not the least, we would like to thank our pillars of the podcast, Dr. R.V. Ashokan Sir, National President IMA of the podcast, Dr. Anil Nayak Sir, Secretary General IMA MSN, Dr. Shalak Gupta Sir, National Chairman IMA MSN, Dr. Akshay Yadav Sir, National Convener Standing Committee IMA MSN, Dr. Arjit Bansal Sir, National Convener IMA MSN, Dr. Predish Narayanan, General Secretary Academics, members of the Research and Academic Subcommittee, and Digital Partner Clonet. This podcast would not been possible with all of your support and hard work of all. I once again thank you for all attending this meet. Hope to see you all in the next episode. Till then, stay tuned. Thank you.
Thank you so much, ma'am. Thank you so much for giving us the opportunity to host the session. Thank you so much, everyone. With all your permission, I'm closing the session over here for today. Good night.